Thank you so much for the opportunity, and thank you for the introduction today. So to get us started, I would like to take this opportunity to acknowledge the traditional territories of the Treaty 7 region in southern Alberta. And the city of Calgary is also home to the Métis Nation of Alberta Districts 5 and 6. And on this land and in this place, we strive to learn together, walk together, and grow together in a good way. So I've received some funding from the following institutions or organizations, but I have no conflicts of interest with the material in this presentation, and the opinions here are my own. So I'd like to just take you on a quick journey describing the focus of my talk today. So as you heard, the session for today focuses on methodological challenges in epidemiological studies on non-pharmacological interventions. And one of those challenges are understanding and measuring adherence on non-pharmacological interventions in the context of research. I will also disclose that I do not have significant experience with cluster randomized controlled trials, hence I'm here to learn, but that adherence will be discussed in the context of cluster RCTs and in the area of healthcare, which is where I work. I will discuss the challenges with adherence and present strategies to potentially overcome these. So right away, the key takeaways from today's talk is that adherence is crucial for successful healthcare outcomes, both in practice and in research. The adherence can be challenging to understand, measure, and include in our analyses and report on cluster randomized controlled trials. But at the end of the day, both the scientific and human dimensions of adherence need to be considered in future guidance related to randomized controlled trials. So very briefly, cluster randomized trials, as we know, we randomize groups rather than individuals to interventions, and these are commonly used to evaluate public health, primary care, and healthcare interventions. And this design aligns with pragmatic trials, allowing for the evaluation of these interventions in real-world settings where we know non-adherence can occur. And they're often chosen, though, for logistical reasons, such as simplifying intervention delivery, so working within the system to deliver your intervention, reducing potential contamination across groups, and improved adherence within the intervention. So if we're saying that improved adherence with the allocated intervention is one of the common reasons for conducting cluster randomized controlled trials, let's get into a little bit what we might mean by adherence. So the WHO defines adherence as the extent to which a person's behavior, such as a lifestyle change or taking a medication, is agreeing with the recommendations from the healthcare provider. In the context of research, it's the extent to which participants receive their allocated intervention as intended. However, compliance can be defined as the extent to which a patient's behavior matches the healthcare professional's recommendations. So it sounds kind of similar. But according to this article by Murr, adherence is an active choice of patients to follow through with the prescribed treatment or intervention that's provided while taking responsibility for their own well-being, while compliance is more of a passive behavior where they're just following a list of instructions from their doctor or provider. Some have argued that the WHO definition focuses only on patient behavior and doesn't look into that shared decision-making that happens between patient and care provider, while compliance is really just following a list of instructions. Adherence is the preferred term because it does respect patient autonomy, and that's what I'll be using throughout the talk. So, although non-adherence can occur in individual randomized controlled trials, factoring in intervention adherence in cluster randomized controlled trials are much more challenging because of the hierarchical nature of the design and the delivery of the intervention in these types of studies, where at least you can have two levels of deviation occurring from the protocol. So you can have deviations at the individual level, which you see here, or you could have it at the cluster level where a cluster might drop out of the study altogether, or you can have a combination of both. So it does really complicate some of the interpretation of our results. So as just an example to illustrate that, we here in Calgary conducted a study using a stepped wedge cluster randomized controlled trial to assess probiotics for preventing primary hospital-acquired Clostridioides difficile infections. At the cluster level, adherence was 100% because the intervention was enabled by our electronic medical record, and we had no clusters drop out or no facilities drop out of the study. But when we looked at the intervention at the individual level, that ranged from 77 to 85%, depending on the phase of or period of the project. So why does this matter? Why am I talking about this, and why does non-adherence occur? Well, when non-adherence occurs in these studies, the randomization that we built into these studies can no longer guarantee that the relationship between the intervention and the outcome is unconfounded, and that then leads to threats to internal validity, introducing selection bias. It can also reduce our statistical power and can result in a diluted treatment effect and an intent to treat analysis. But in the end, all of this could impact the interpretation of our results and ultimately the decisions around implementing the intervention in the long term. So just kind of as an example here, in a review of 76 individual randomized controlled trials of non-pharmacological interventions, only 49 undertook an analysis to adjust for adherence. A majority of these studies, so just over 67%, did not show a difference in their findings after conducting a sensitivity analysis accounting for that non-adherence, but nearly a third of the trials did see a change in their interpretation of their findings. And in another subset of these studies that conducted adjusted analyses in their models, 22% of them did see a change in their results. So certainly can then complicate our interpretation potentially of the findings. In another review of 123 cluster randomized controlled trials of both pharmacological and non-pharmacological interventions, and as you can see, most of those were cluster RCTs of NPIs, only 50% of those studies included any information on adherence. And of those, 19 presented an adherence-adjusted analysis. However, even in those, no study reported the assumptions necessary to conduct those analyses, and the information that was provided was inadequate to provide any meaningful interpretation of the study results. So now let's try to understand why non-adherence occurs. So this paper longitudinally analyzed how subjective perceptions of COVID-19, the community, and government influences adherence to public health measures. They used an international survey of 3,000 respondents, and it examined personal risk perceptions, social norms, and political views as predictors of adherence. And they identified 3 levels of effects of personal behaviors regarding these health interventions. So we had first order effects, which are those personal risk perceptions and how that influences our behavior and our willingness to follow measures. Second order effects, which are the social norms and our communities that we live in, and how that influences social distancing and what our community expects of us. And then third order effects are those broader, more political government influences and the support for that, and our trust in the government and the community. The clarity of communication from the government on the virus is what sort of can influence our behaviors to follow mandates or to protest them. So we have done a little bit of work here to understand these types of factors influencing behavior related to personal protective equipment, or PPE, in long-term care, and also looked at the adherence with the practice of admission screening for antimicrobial resistant organisms in hospital. And ultimately, the goal of this work has been to inform how we might consider designing an intervention that staff can adhere to improve practice. And so one of the studies that was conducted by Christian Sang, one of my previous master's students on long-term care in Calgary, did identify some barriers related to PPE use, including lack of knowledge around PPE, familial obligations, sense of professional duty, and social influences. So again, you start to see those 3 orders of effects in play. But overall, lots of different reviews have looked at the adherence factors related to infection control and social measures among healthcare workers. And similarly, we see the spread of barriers or facilitators that can fall within those 3 orders, including the impact or belief of PPE and the impacts that it has, comfort, workplace culture, communication that they receive from their leadership, managerial support, and resources available to them. So we've covered why it's important to understand adherence, what factors might contribute. So what's the methodological challenge here that I'm trying to relay to all of you? But really, the first issue is that in the literature, there are multiple, often conflicting definitions of adherence, including terms like I introduced, compliance, but then you see fidelity, engagement, responsiveness, receipt, reach. All of these get sort of mixed together under this umbrella of compliance or adherence, and really different interpretations of each word. But beyond terminology, a number of different challenges exist with non-adherence, and it's essential to recognize that multiple factors are at play that influence adherence in practice, but also in these cluster randomized controlled trials. And as I introduced earlier, within these cluster randomized controlled trials, factors that influence adherence can occur at these various levels, which adds a layer of complexity to our understanding. There are multiple methods of measuring adherence, which I didn't get into, many of which are subjective, not validated, can't be replicated, leading to variability in the quality and content that's presented in these studies related to adherence. So although we have current guidelines that are meant to help us report on this, there is a lack of reporting on adherence at the cluster and individual level within cluster randomized controlled trials when reporting on them, and as noted also in the reviews that I introduced earlier. So what are some strategies to consider? There are a number of them, all listed here, from ideation, developing understanding and trust among your partners, to reporting and developing new guidance. And ultimately, just to highlight a few of them that I think are quite important for my thinking, is really engaging with those behavioral scientists, those social scientists, implementation scientists, to fully comprehend that human dimension of adherence, to really lead to better understanding of the predictors of adherence so that we can design effective interventions that hopefully will be successful. We want to follow best practices and the guidances that are out there when we are reporting compliance. But ultimately, what I've gathered from preparing for this talk is that we just need more research in developing better guidance on how we can and should be reporting adherence in our trials so that we can try to make sense also of some of those challenges. So again, key takeaways: adherence is crucial for successful healthcare outcomes in practice and in our research studies. It can be challenging to understand and measure and report, and at the end, think about both the scientific and human dimension of adherence in future guidance related to adherence in the context of randomized controlled trials. So with that, thank you very much for your time.